I'd like to introduce Dr. Caroline Kiser. I don't know if you were here this morning or not, but she's the Dr. Bacon, is how I'm going to refer to her as. She can explain it. So,
she can explain it.
Without further ado, Dr. Kiser.
Thanks, Dr. Ray. Thanks for having me back this afternoon. It's a great panel we've got up here. It's always hard to follow the Charcot extraordinaire expert, Dr. Burns, but I'm going to try. I'm actually giving this talk on behalf of a former resident of his, so we're just going to try and get through this quickly together. So the Superconstruct to the rescue, what to kind of do with these Charcot wounds, Charcot deformity, and how to approach them. I have no disclosures pertaining to this lecture this afternoon. So just a kind of quick survey around the room. Who primarily, when you're fixating your Charcot reconstructions, is using internal fixation? Show of hands. Okay. What about primarily external fixation? Nobody. What about a combination of both? Yeah, perfect. And then who just says, yeah, forget it, I'm going to refer it out and not deal with it? Yeah, you guys are the smart ones, absolutely. So basically just kind of some quick objectives of this lecture, just to go through the basic pathological limitations of Charcot reconstruction, kind of understand the role of the supplemental fixation or the Superconstruct as it applies to Charcot foot deformity, and then understanding some of the emerging techniques regarding Charcot reconstruction. So really, for me, what dictates what type of fixation I'm going to start with is my soft tissue envelope. Are the wounds healed? If they're not healed, I definitely don't want to consider putting in any permanent fixation. You want to make sure that there's no residual bone infection. You definitely don't want to go disrupting soft tissues that are already disrupted. So for me, getting the wounds closed, putting on a frame, it allows you to kind of dial in your deformity correction without even sometimes making any cuts. A few little minor soft tissue releases. You offload the wound by putting the frame on. These wounds typically will heal up. After you've done that, you can go ahead and then consider your permanent fixation, usually then internal fixation. I'd like to leave the frame on while I'm still using the internal-external fixation. Think about if this is your primary surgical intervention. You have a lot more options. Nothing's been done. You have pretty much everything on your shelf. Or if this is a revision, do they have hardware that's in there? Do they have hardware that's failed? Do they have hardware that you have to try and take out? These are all things that kind of consider will more or less dictate which way you're going to go with your fixation options. So kind of what we've all heard this morning, this whole afternoon, staged procedures. So Lamb in 2010, Zagonis in 2012, Samarco in 2009. Everybody kind of advocates this staged reconstruction. Allow the soft tissues to heal, get your wounds closed, and then work on correcting your soft tissue and osseous deformities. Pat makes this look really easy. There's obstacles at every turn when we talk about these Charcot patients. Really, kind of one of the big ones is the bone quality. These patients have just dissolution of bone. You'll get x-rays and you'll be missing a cuboid. You'll be missing half the cuneiform. You don't know where the medial cuneiform is. These bones are in tiny little pieces. They're obviously usually very poor stock. They're not stable. They're not strong. You get fragmentation of the bone, osteoporosis. And these patients, they usually have these crazy high A1Cs. They have glycosylated tissue. The tissue is sticky. It doesn't have that flexibility that you want. The last thing you want to do is do an extensive surgery, have them swell up, and you've done yourself a disservice. So you got to remember they've got glycosylated tissue. You need to take the tension off of the tissue. Tenotomies, shortening the foot, anything you can do to try and decrease the tension on the tissue. So they have poor vascular supply. So you don't want to go making big incisions, top of the foot, bottom of the foot, wherever, if you don't have vascularity. If you don't have vascularity, those flaps aren't going to help you either. So, make sure that you're checking on that. Impaired nutrition. These patients always have, A1Cs of 10, 14. Are you routinely waiting to delay any intervention until their A1Cs come down? I do. I like to try and get my patients' A1Cs optimized below 8. There's a ton of studies that show you get your A1C down below 8, you're going to have better outcomes. And these patients are usually inflexible and overweight. Trying to manage them postoperatively, they're going to have prolonged periods of non-weight bearing and immobilization. Are they ready to handle that? Are they going to be able to get around, do what they need to do, and transfer safely while maintaining their non-weight bearing? And then really, standard fixation principles, these are not standard patients. This is not standard tissue tissue that you're working with. This is not standard bone. Standard fixation is just not gonna be enough here. So we talk about bone mineral density. This bone is really soft. If you look at across the board, this chart on the right, the bone mineral density is actually the highest Greenhagen found in 2011, pretty much within 2 years after your Charcot event, and it just continues to decline. So when you're thinking about how soft that bone is when you're in there primarily fixating this, know that that bone's gonna get softer, it's going to get worse. You're gonna need extra fixation, you're gonna need extra mobilization time. This bone is just not as strong as it needs to be. Christensen also looked at that bone mineral density in acute Charcot. Again, it's just not there, it's just not strong enough. We need to give something to make things stronger. So why is the bone so soft? Yoho in 2009 looked at vitamin D levels in patients with diabetes and not diabetes and found just as a trend, vitamin D was lower in patients with Charcot neuroarthropathy. Jeff Cope looked at basically the bone markers to look at the difference between your osteoclastic activity and your osteoblastic activity, and you have a disproportionate increase in your osteoclastic activity versus your osteoblastic activity. This kind of brings us to this RANKL OPG pathway. RANKL is a cytokine responsible for bone hemostasis, for vascular calcification, for keeping bones calcified and strong. Then you have this OPG, it's a TNF-alpha pro-inflammatory cytokine. In high concentrations, it inactivates this RANKL. So you have these diabetic patients walking around on an insensate foot. They increase their inflammatory response, which upregulates your production of your inflammatory cytokines. Your OPG goes up, it decreases the RANKL, and you start to just get soft bone. So here's case one, 53-year-old male patient comes into the office. You can already tell right away, you're looking right at that talonavicular joint, something's going on here. You get the lateral, and there you go. This patient has a complete plantar flex talus, complete disruption of your Meary's angle. If left untreated, this patient's just gonna go on to ulceration medially. So really, you gotta work on restoring that talus metatarsal angle. Preoperative non-invasive vascular studies, really good for this patient. Likelihood that they're gonna at least heal from a vascular standpoint is pretty good. So you gotta do what you gotta do to get that talus metatarsal angle. Stick a lamina spreader in there, stick a cob in there, crank it up. Shan's pins are really great. You can use them to joystick, to tug things around. You have to restore the deformity to prevent ulceration. And then you throw your fixation, and kind of what we've talked about when you look at what the bone is like. Is this enough fixation? Probably not. Because a little bit later you can see continued collapse of the talus, a little bit of a broken screw there. Still a plantar grade foot. Is this gonna stand up to the test of time? Who knows? So you can throw the biggest, baddest nail. What do you do when something like this happens? This is the one you refer out, right here. Refer this one out. So that kind of brings us to Superconstruct. So Samarco kind of described the Superconstruct, and basically the purpose of the Superconstruct, really the takeaway from the lecture, is fusion is extended beyond your zone of injury to improve fixation stability. So you want to try and grab bone proximal to where your deformity lies and distal to where your deformity lies. This bone is going to be a better stock. You're going to get better purchase of your fixation. Overall increases your stability. You're going to want to resect bone. You want to be able to shorten the extremity. You want to take tension off those soft tissues so things can heal up and you're not dealing with a bigger problem. You want to try and use the strongest device that can be tolerated, and you want to try and position this to maximize your mechanical function. So what are your types? We have planar plating, locking plate technology, axially placed screws or beaming, intramedullary fixation, and then a hybrid fixation, utilizing a combination of a few of these properties. So planar plating, the purpose of this planar plating is to span the area of the Charcot. So back to that Superconstruct, you want to grab bone distal to where your Charcot event is occurring, and you want to grab bone proximal. You're going to grab bone in the interim, but you're really kind of relying on these buttresses or this quality bone sandwich, good bone on the proximal side, good bone on the distal side. This tension placement converts the tension side or the planar side of bone to more of a compressive force, again, trying to just get things to heal up as best we can. Some limitations to this planar plating, excessive dissection and periosteal stripping. So if you're, especially for medially based incisions, you're stripping a ton of blood supply off the periosteum. How do a lot of bones heal? From the periosteal blood supply. You strip this all off, you can increase your wound complications, and you're right back to where you started. Locking plate technology, I think these are a really great and powerful tool to use in the Charcot foot. They have a fixed angle construct. Now some of the companies out here have a variable angle construct. It's an excellent choice for osteoporotic bone. I highly consider using it when you think and you know that the bone mineral density is just going to decrease over time. You know, if you're not dealing with osteoporotic bone, it's going to turn osteoporotic at some point. So axial screw placement, or this beaming technique, you can use solid or cannulated screws. They're placed within the medullary canal of bone. Or you can either throw them anterograde or retrograde. And usually just a medial beam, even if you just have medial deformity, is not enough. You really need to consider this lateral beam, or this calcaneus to fourth metatarsal, or third, fourth metatarsal to calcaneus, really trying to restore that tripod structure and support to the foot. So for your axial screw placement and actually getting these placed, it really helps in reduction of your deformity. You're trying to get a straight Mary's line. You throw a really, really long 6.5 millimeter screw or beam or bolt through that medial column. It gets that correction for you. Just always make sure to get an AP of the ankle, because you don't want to have the patient finally start walking and say, "Doc, I got pain in my ankle," and you look and your beam is right in the medial gutter. It happens. Don't forget that AP of the ankle x-ray when you're in there. The nice thing about this fixation, it is perpendicular to your arthrodesis site, so it does help afford you a good perpendicular compression. And eliminate stress risers. You also don't have any exposed hardware. It's a very minimal exposure. You just make a small incision over the first metatarsal phalangeal joint, either dorsal or plantar, kind of depending on how much motion you have. And you really can do some of this percutaneously if your joints have already been prepped, or you've done a small osteotomy. So you can do these things to really try and limit your soft tissue exposure. And these things, because they're intramedullary, accept both dorsal and plantar tension. So really the placement of these, like we said, you want to restore that Mary's angle, that tripod attitude to the foot. So your medial column beam is going to be straight down the center of your first metatarsal, through whatever cuneiform's left. Usually the talus is there, so as long as you're capturing first met and you're capturing talus, you've pretty much hopefully restored the medial column. The lateral column placement, again, usually around fourth metatarsal base, capturing the cuboid into the calcaneus or vice versa. You just want to make sure you capture that to kind of lock in that lateral column, kind of prevent that cuboid subluxation, which we so commonly see in midfoot Charcot. And then subtalar fusion. This is just kind of an adjunct. You want to lock up the rest of that hindfoot motion. You don't need it. You're trying to just create a stable plantar foot that they can walk on and not ulcerate. And really, joint preparation is key. Whether you're taking osteotomes, rongeurs, burrs, you're taking out a huge wedge of bone, you're taking out articular surfaces, you get good joint prep, you get good hardware placement. Hopefully these things are going to fuse for you. Intramedullary nails, these are going to allow axial load. They can be dynamized. Some studies show that they're kind of superior to external fixation. That's for your uniplanar external fixators. I really think you want a Superconstruct. You can throw a nail on plus a ringed external fixator. I don't know how much stronger you can get than doing that sort of a construct. So hybrid fixation, using your locking plates and beaming. Kind of one downsides to beaming is you do, if the patient weight bears before they're supposed to and you have isolated beams, can get some rotational forces. If you haven't adequately prepped the joints, you can get some migration of these beams or bolts within the metatarsal. They can extrude out the back of the talus. They can fall planarly. So something to consider is throwing in some sort of locking plate or a plate construct. Prevents any sort of rotational angulation of forces while these patients heal. The other big thing is to kind of remember the double rule. I know it's been talked on a couple of times today, but for these diabetic neuropathic patients, you're going to want to think about trying to double your fixation. So usually, if one's good, two's better, definitely the case. Double your fixation, double your postoperative follow-up for these patients, and double their non-weight bearing time. So this internal and external fixation combination, you kind of look at the picture on the left. This is something that if they don't have a wound now, if you let them go, they're going to break down and get a wound. If you can get an external fixator on there, kind of correct the deformity, let things calm down. If it's an acute stage, let things coalesce a little bit. then you're ready to just leave your external fixture on, go around it, and place some sort of permanent internal fixation. It protects really against the loss of fixation if you kind of use a combination approach. In case number 2, 60-year-old female comes in again. She's got this horrible kind of mid-foot Charcot. She's got a wound planarly on the bottom of her foot. Without doing some sort of deformity correction, all the offloading in the world is just not going to do enough. And as soon as she steps back down on that foot without her protection, it's going to re-ulcerate. So options for this really go through mid-foot osteotomy, shorten the foot up, kind of like Dr. Burns had talked about. You want to shorten the foot up, decrease the plantar tension that's on that wound from that rocker bottom shape to the foot, and then just stabilize everything and start thinking about throwing your beams. That picture on the right kind of shows you see that. There we go. We got our fixation pin here. You get that lined up, it corrects that deformity for you. If it puts in a nice straight line for you to follow, just check the ankle joint, make sure that you're not in the ankle joint. These things are pretty easy and quick to put in. The nice thing about the beams is you're not drilling and filling forever. You get your guide wire placed, you drill, you ream, and you can insert. These things close up pretty good. Again, you can then completely excise that ulcer on the bottom of the foot because you've now shortened the foot, taken the tension off the plantar soft tissue structures. These things heal up pretty good. Here's what the patient looks like postoperatively. Again, we got anterior grade beams, retrograde beams. Case in point though, that rocker bottom foot is now no longer a rocker bottom. So in conclusion, these deformities can be limb-threatening deformities for sure. Don't undervalue non-surgical options. Some patients can do great with a crow walker, an AFO type of brace, proper offloading and shoes, proper orthotics. Currently there's weak evidence within the literature to support ideal operative treatment, and that's because, just like Dr. Burns said, there's no 2 Charcot feet that are the same. So to try and standardize a treatment plan, you really just can't do it. What really you should take away is the fixation principles and really just stressing zoning or spanning the zone of injury. Capture good bone proximal to your Charcot area, capture good bone distal to it. That stuff in the middle kind of coalesces as long as you've got kind of 2 stable points of fixation. Use the strongest fixation you can. So if that's beams and plates in your hands, if that's beams and external fixation, something that you can do, consider 2 different types of fixation to really stabilize these patients while they heal. And really just double everything. Double the postoperative time non-weight bearing, double the postoperative visits, and double your fixation. Thank you.